for joining Rural Hospitals Achieving Success, an Amazing Journey. Before we get started, I'd like to first give our instructor, Marcia Cheadle, a chance to introduce herself. So, Marcia.
Good morning. My name is Marcy Cheadle. I'm the Director of Clinical Information Systems at Inland Northwest Health Services. And I have the pleasure of working with a number of hospitals across the United States, implementing advanced clinical technologies in an effort, to a large degree, to meet the government's ARRA, or Meaningful Use Stage 1 initiative. Over the past several years, I've worked with probably over 20 hospitals, primarily critical access facilities, on those successful journeys. And today's presentation will really provide an overview at a high level of some of the strategies that we've been successful with in working with these particular hospitals. So the overview of today's agenda really will look at, again, how we've worked particularly with our CAW facilities to successfully achieve Stage 1 meaningful use, sort of moving many of them onto the Stage 2 strategies and looking at that program for next year. Some practical applications that we've deployed and executed on at the critical access programs for leveraging their talents to achieve Stage 1. And then really how we've worked with them to design a program that prepared them more for the Stage 2 platform. Today's program will talk kind of on an overview level of four particular areas. One is looking at some of the barriers that we found unique to the critical access area, really looking at preparing and planning for that, looking at regulatory programs in general, and what is really the vision of the federal government. We'll then look at some or talk about some practical applications and how do you really execute on a plan for moving your programs to meaningful use. And then finally, looking at what we call the next race, ensuring that your programs and your communities are leveraging the healthcare technologies that were deployed for Stage 1 to meet the Stage 2 and subsequent regulations by the federal government. So again, as I indicated, we've worked with a number of hospitals beginning this journey in 2009. These are independent facilities. They are not owned or operated by a large corporation to a large degree anyway. And in early 2010, we did an evaluation of the sites that we particularly were working with very closely and selected 12 of the 20 to move forward with Stage 1. And we worked with their leadership to see if that was something that those hospitals were interested in. So in 2011, we had 9 critical access hospitals and 3 larger entities hospitals attest for meaningful use Stage 1, both Medicare and Medicaid funding, incentive funding programs. And then in 2012, we then worked with 8 additional critical access hospitals, again, with the same sort of methodology, the same strategy that we're going to talk about today on moving them successfully forward with Stage 1 programs. And now we're working with 2 critical access hospitals and other larger hospitals on meeting Stage 1 in the 2013 year. And I also work with a lot of hospitals across the nation sort of ad hoc. So in our service area, we do both hosted and non-hosted strategies for our hospitals. So the experiences I'll share will be from both of those realms. In addition, another metrics of electronic medical record adoption is the HIMSS-EMRAM model. And we have found quite a correlation between Stage 1 criteria by the federal government and the HIMSS model for electronic adoption, and have positioned many of our hospitals, 6 of them now, I think there's actually 9 right now, for Stage 6. And I just recently had the call with HIMSS in one of our critical access hospitals on Stage 7 application, and look for that site visit in June of this year. So over the next about 40 minutes, we're going to quickly talk about kind of how we are approaching meaningful use. And for the first 3 slides, we're going to go over some of those barriers and how you can kind of look on how you are going to best prepare and plan for engaging on the meaningful use journey with kind of what's coming out from the federal government. And the first slide really I talk about how you're going to prepare from a language perspective. The number of acronyms and changes that are coming out in terms of language definitions by the federal government is astounding and really overwhelming to many of our critical access hospitals. And what we encourage you to do is begin to get yourselves a book to define what these particular acronyms mean, and then more yet how they apply to your program and your community, and how you're going to interweave your strategies with sort of what the vision of the federal government is. So, for example, the first one, HIE, Health Information Exchange. What does that mean for your organization? What does that mean for your community? There's health information exchanges in states, in regions. And there's a lot of ways to interpret that for your hospital, and it's important for you to garner what you want to achieve from a health information exchange for your population and your providers. Interoperability standards, these are all words coming out from the federal government, all with very strong definitions. And it's really imperative that as we begin to dialogue with other entities, or state vendors, that kind of thing, that we really understand what these words mean, because a lot of people are using them and they may sort of allude to different definitions. These are unique definitions as it relates to the Meaningful Use platform. Next thing that we see is sitting with our hospitals to look at what resources do you have? Where do you sit in terms of positioning your organization to meet meaningful use? And what are some of the unique challenges that you have? It may be the same in certain cause or may not be the same, but things like personnel. What personnel do you have available to work on meaningful use? When I started in 2009, we took 3 people to move just to meaningful use. That's all they do. We now have 5 people on that particular platform. And it's important to understand, do you have that resource or not? And if not, that's okay. There's a lot of resources available you can tap into, but kind of doing a current state of your particular hospital, looking at your solutions, what you've done creatively in the past, and how you've used personnel in those creative solutions. Looking at your budgets, making sure your CFO has budgets set out to target the meaningful use and capture those dollars accurately on what you're doing to attain meaningful use, both in the hardware, software, and then personnel budget-wise. And there, again, are resources available from a dollars perspective. The Medicaid AIU funding, the Adopt, Implement, Upgrade is a funding source if you purchase certified hardware and software that you can then use to use that dollars to then further your meaningful use program. One thing that I really encourage hospitals to do is sit back and look at the expertise and experiences within their organizations. What typically we see is that the organizations have done very, very well in developing solutions, very creative, innovative solutions for how to get things to work in their organizations, in their hospitals. But that may not be the expertise, the same expertise required to meet meaningful use. And so we need to understand if you have that or don't, and where we're going to fill the gaps for those types of services. ICD-10, the reason I put this on here, is ICD-10 is a threat to us, right? For those of us on a meaningful use journey, we have about 26 projects perhaps running in parallel that all are aligned to hit the meaningful use time frame. Well, ICD-10 is a government-required program that's coming in. It has to be in place by October 1st, 2014. And so as you align your programs, as you align your timelines and strategies, you need to have areas in there that you can add other regulatory programs like ICD-10 and understand how those might be weaved into the current project plans that you're doing. So always save room for those, the next best thing that the government's thrown our way to ensure that we have what we need, the space and time to meet our timelines. Certainly the pace is critical. The government's defined the time frame, it's defined the pace, and the payment penalties are coming in 2015, 2015 we have payment penalties. So you have plenty of time to hit Meaningful Use Stage 1 and get yourselves on that journey before payment penalties. But you can't spend a lot of time trying to figure this out, right? You got to start. And then the thing that we've seen over the last couple of months in particular, and it's hit the news, is where the programs, as we increasingly put data into an electronic platform, these programs must be available to the clinician. They must be up They must have the data available when the clinician needs to care for that patient. So a lot of our hospitals do not have a strong disaster recovery program or a strong infrastructure for a redundant program. Even our large organizations haven't necessarily put time in this. And it's just something to consider. It's not that you have to have it buttoned up by the time we hit meaningful use, but we need to have it in our back of our minds. What are we going to do if our program doesn't stay up? And we really need it to stay up as we're encouraging providers to spend more time in the electronic platforms. And then the third thing is to educate our folks, educating them on the rules, on the goals, on what we're trying to achieve in meaningful use. Because, again, just like with the language changes, these rules are here, and they're very prescriptive. The government has very, very well-defined program achievements, what it's looking to get to. So they're in the form of these things called core and menu objectives, standard, and measures. And for each objective they've outlined, they have a standard to meet that objective and the measure or threshold by which gets you success for that particular stage. One of the things to keep in mind that as these Stage 1, Stage 2, and Stage 3 platforms begin to are unveiled by the federal government, they increase the measure. They increase the threshold of the objective and the standards that we have to meet. Quality measures I call out because quality measures is being moved out of the platform of meaningful use as just an overall expectation. An expectation that folks have at each of their institutions that you will, from an ARA perspective, meaningful use perspective, you will complete the quality measure requirements and submit that data to the federal government. Now, the problem with quality measures is it does not align with the current quality measures that you are submitting to the federal government. And so you want to be very, very cautious and careful, very deliberate about what the data is that you're sending because we don't want conflicting data going to the federal government in any way, ever. So it's sort of aligning the qualities, programs you're doing today, those measures, those metrics, and moving those into the ARA quality definitions. And when that won't work, right, when that isn't going to work for us, then we know what we're going to do and how we're going to handle that and how we're going to explain that. Other things that are unique in the ARA platform is you can include your emergency department or not. You always have to include your inpatient populations and your observation. That's what OBS is, observation patients. But you don't have to include the emergency department. And one of the things you want to keep in mind is in your CAW facilities, particularly some of our smaller CAWs, your inpatient census is very low. And so if your threshold is 80%, you need to pretty well be at 100% on adoption in order to be successful with your measure because you don't have half a patient, right? And so you may need, what I encourage our CAWs to do is develop both platforms, the emergency services area and our inpatient areas, if you have time, and then as we get closer to reporting, we'll pick the best strategy for the best numbers for the reporting period. And for the first year, for Stage 1, you only have to do 90 days, right? And so 90 days equals year 1. Now, year typically in most of our minds is 12 months, but for the federal government rule, 90 days is your first reporting period. That's 90 consecutive days of meeting each core and menu objective that you choose and making sure that you can report on that they are meeting threshold the whole time. You cannot be implementing during those 90 days. And that during those 90 days, you are using certified software that has been tested by federal government certified programs or agreed programs like Drummond or CCHIT, that you use those vendors and their certified versions to meet your meaningful use criteria. The other thing that's unique for hospitals is that the government uses the fiscal year for hospital reporting. So on October 1st, the year changes. So October 1st, 2013 will be the 2014 reporting year for meaningful use. And that issue becomes when we do a 90-day consecutive reporting, the last day we could start our reporting for any year would be July 1. Okay, so we're in April. So if you haven't started preparing for Stage 1 this year and you still want to achieve Stage 1 this year, there are ways, but it's pretty creative and innovative to get there. Medicaid AIU funding, that is a funding source available. Every state has adopt, implement, upgrade dollars, and you have to just prove that you own the software, that you have licensed the software, and then you can have potential funding dollars for implementing meaningful use. The other thing I want to call out is that in the meaningful use rules, they combine the rules with eligible provider and then your eligible hospitals, right? So the hospital rules, whether it's PPS or CAW, are very different than the eligible provider rules. And so you need to make sure when you're dialoguing with stakeholders and with others in your organization that everybody knows what year you're talking about, that you're looking to attest, which program you're talking about, whether it's eligible provider or CAW, and again, what programs, whether you're going to use your inpatient or whether you're going to use your ED as well. Okay, so the next 3 slides really talk about why we're doing this. What is the goal of the federal government? Well, obviously the goal is to reform the healthcare platform, particularly related to dollars. It's a payment reform model. And one of the best documents I've read that relates to what this vision is called the PCAST report. And the PCAST report is the President's Council of Advisors on Science and Technology. And in December of 2010, they published a document called Realizing the Full Potential of Health Information Technology to Improve Healthcare for Americans, the Path Forward. And that Path Forward document really outlines what the federal government is looking to do over the next 5 years. Right? And we remember they published it in 2010, so we're already in year 3. All right, so they're looking to align dollars as it relates to quality outcomes, demonstrable quality outcomes for hospitals. And they're doing a number of ways. They're looking at a number of ways to do that. Accountable care organizations is one way that combines organizations, combines patient populations, and manages dollars against that patient population. Medical center homes is another model, value-based purchasing. These are all models of services that the government is trialing to see how it can best control the cost of care. Our role for hospitals is just to begin the journey of meaningful use. Just begin to enter data in a certified, structured manner, in a certified platform, in a coded and structured manner for that data element, that critical data element designed for the patient, right, that you collected on that particular patient to be shared with other clinicians who care for that patient. So stage 2, which begins in 2014, again, which is the October 1st, 2013 date, that begins 2014, year 2, stage 2 is all about the data exchange and promoting this coordinated care, promoting all people who deal with that patient, giving them the joy of information that you contribute from your hospitals so that we can have the best overall outcomes for our patients. And then in stage 3, which is coming further yet, is all about then reporting on those outcomes for target goals and target incentives to reduce overall costs. We will be looking at the quality reports to understand what community population health needs to look like and what that should cost. In order to support the vision, the government came out with a number of objectives. And their objectives are patient safety, right, privacy and security, and we know that, right, because the new HIPAA rules came out in January. Care coordination model. The care coordination means how we take data and hospital or healthcare data and include the patient and all care practitioners, care deliverers to do the best treatment plan and follow the best treatment plan for that patient to optimize their health. We'll be looking at overall population public health that I described in stage 3 coming. And then this new issue you'll hear a lot about this year about patient engagement, family engagement, having the patient in their record, seeing their record, taking part of their care treatment. Now, again, what part do we play? What part do we play to support the objectives that support the overall goal, the goal of shared data? And all we have to do in our hospitals is input the data. We got to input the data today. The systems, the vendors themselves will take care of the mapping, will take care of normalizing that data so that it can report outbound. You, hospital, need to get the data in. You need to identify which data elements you're inputting. And again, very prescriptive model by the federal government. You don't have overall choices, right? You have some choices. But the key with implementing the data streams is implementing in a way that clinicians will adopt. We're implementing it in the clinical workflow. We will then take those data streams from a software and hardware perspective and map it to the technology standards required for sharing that information to other sources, to other EMRs, to other hospitals for outbound reporting. So this is all the hospital has to do, our section right there. Okay. Now the next 8 or so slides is going to talk more about how do we get started? What are we going to do? This is not lengthy time, right? This is just what are we going to sit down and do? And the first thing we have to do is to educate our leadership, to establish a leadership team. And all hospitals have a leadership program. They have the C-suite, right? Your CEO, the CIO, the CNO, those people we need to teach, we need to educate on meaningful use, on the ARRA program, and then have some sort of strategy where we report up to them our successes on a biweekly or monthly basis. The C-suite people can move and can mitigate barriers for us. We need them on board. And we need the language to be defined the same. So when we're talking with them, everybody's on the same page. We need to do the same with our clinical team. IT has always been there in hospitals, but in most of our CAH hospitals, our IT strength has been in network infrastructure and desktop. It has not been in the operations view of the clinical realm. We have not been key in implementing clinical systems. So now it's a time where we bring the clinical subject matter experts from the hospital together with the IT core teams, again, educating them on what we're trying to do and understand how many clinical implementations we need to engage in at our hospital to be successful. And the team that I want to make sure we do call out as well is the financial team. This whole program is about registration, attestation, having the budget available to do our program. So we need to make sure, again, that our financial team is aligned with our goals and our strategies for successfully obtaining meaningful use. Planning. Planning is the key, right? So where are you? What is your current state? Analyzing your situation at your hospital as it relates to meaningful use. And celebrating your successes, right? Leveraging your successes in the past. Most people have some kind of electronic platform in their hospital. They're gathering some kind of data, okay, most hospitals. So it's really then taking a look at that, understanding what more we have to do, making sure we understand both from a software and a hardware perspective where we need to upgrade, and then making a plan. So once we've established our current state, then we bring those IT and clinical programs together, the right people, right, the people that do the work. We bring them to the table, and we say, what do you need to get to our goal? What do you need to enter that data? Okay? You need mobile platforms, you need single sign, what do you need to make it work for you? And then we design and we design the acceptance criteria, we pick a vendor and our software and hardware platforms if you don't have one. The next key is establishing timelines. Remember, the fiscal year is changing on October 1st. So we have a 90 consecutive day reporting no later than July 1 of each year. And we need to make sure that we hit our project well above that, right? Because the 90-day, we can't be implementing or fitzing around. We got to be hitting our thresholds consecutively. The adoption must be there. So I like to get everything in place by about June of the year that you're going to look to a test, making sure that you're strong for that last month, and then just pick the day that you're going to test. Now, in 2014, that game changes ever so slightly, and the government says you must pick a recognized quarter. Right, so you can't just pick any day of the year. You have to pick a recognized quarter and start on the first day of that quarter. And as you do your timeline, then we need to do hard dates, milestones, making sure that we have a schedule, that we're marching to, everybody's in alignment, and then we have some way of recording or communicating those strategies to keep people in alignment. And communication strategies are important. Hospital people like to be told they do a good job because they do a good job, right? We want to leverage the great work they do every single day. We don't want to make them do more things. We want to demonstrate how they are doing such a good job. And you need to have some way of doing that, whether it's in Excel or whether you color the cells or we do a dashboard, some way where we train them on what they're doing and the joy that they are bringing all of us at a hospital level by implementing the data, by entering the data that we're asking them to do. The next thing that has changed over the last few years, which we're delighted that it's changing, is embracing evidence. Now, in many of our COF facilities, we have a lot of people who have been practicing there for a long time. Maybe that's the only place they practice. They've been in practice 30 years, like myself. And, you know, we've always done it a certain way. It seems to have worked all those years. Why can't we just continue? Well, like it or not, there is evidence to suggest that if we do things a certain way, we have better outcomes, right? And we have research and knowledge to do that. And you can debate it all you want, but it is out there, and the federal government has it. Not only is it out there, but the ability of this thing to be real time because the Internet is out there. So, and it's not just clinical data anymore. It's how you have to establish a HIT platform for the clinical programs to write on top of to be stable that has best practices. So best practices in data information, structured data, best practices in terms of hardware, software, Citrix, infrastructure, desktop configurations. There's knowledge on clinical decision support. A lot of this stuff, though, is behind the scenes. It's embedded in the software program, so your clinician just has this stuff coming to them. It's a very passive receipt of guiding decisions for care, and then documenting when the clinician decides not to provide the care along the guided pathways, like care plans or care pathways. And it's just becoming more refined, and it's embedded in all the programs, and it just is what it is. Now, the unique thing about CAUSE is you only have certain, let's say, drugs available in your formulary. So you can tailor evidence-based to your unique program and your unique patient population. Easy to do. The next thing we need to look at is aligning all the partners, right? Hospitals have a tendency to believe that everything exists within their four walls. But in fact, as our patients leave our care, right, they engage with other care practitioners, okay? Whether it's the pharmacist, whether it's home care, whether it's their primary care or another clinic, a pain center, long-term care, assisted living care. Everybody is providing care to these patients. And as a community service agency, which a hospital is, we need to align ourselves or our partners with us, at least letting them know what we're doing so everybody has a heads up on success as we engage in outcome data for our patients. In addition, we have to look at how is it we're going to educate these people. So in our long-term care division, they are being inundated with their own regulations all the time. And so it's a matter of aligning that, depending on how close they are with your COF facility, whether they're part of, a wing of your COF facility, or whether they're a separate entity. It's aligning all of those regulations, training everyone to them so we don't get confused. We have a clear vision of where we're going, and that we can communicate that clear vision. And as a matter of fact, not only do we have a vision, but we're going to measure that vision. We've established criteria by which we're going to measure, and we're going to report those measurements. We're going to report our successes, not just in the quarterly QI reports that have been done in hospitals all the time, but in a very assertive way, saying we have met the threshold for caring for our acute heart attack patients, for our diabetic patients, that we have metrics aligned within the hospital and with our program, the Meaningful Use program, so that we don't come in conflict. We don't cause confusion for our providers and our clinicians of what we're asking them to do. And then we want to report that. We want to report that they're doing a great job, which is called adoption. Because our program, by the way, really is about the Medicare patient, right? But hospitals care for all patients, and so we want this great work aligning with all patient care. And our report cards, when we get to attesting to the federal government, we will then be able to include and exclude what the government has decided for the right patient. You know, where our pediatric patients lay, where our, geriatric patients might lie in at a station. The other thing that is very fascinating to me, as I pointed out in the very beginning, is the HIMSS analytics model, the MRAN model, has measures that say there is demonstrable proof that if you align your adoption technologies along a certain pathway, which the federal government, by the way, to a large degree followed, you will have predictable outcomes. You will have return on investment, demonstrable return. And so we can align our MU strategies, mean for use strategies, with the HIMSS analytics model and position your hospitals for very high levels of integrated technologies and adoption and utilization of the data in an electronic format. In terms of implementations, we have to look at how do we implement these things in our hospital? How do we make it work, right? And where are we going to implement along the strategic plan, along the strategic timeline? And with implementations, along with the development of the software program and the deliverables, you need to have dates. And these dates need to include training dates, go-live dates, support dates. And along this timeline for implementing, you have to outline all these work efforts. So you have 26 projects moving forward, all at the same time for meaningful use. Again, some are easy, some are not as easy. But along the way, you want to show how you've embedded the implementation components, the implementation methodologies, such as training, such as readiness, such as go-live. And nothing will provide you more success than embedding the MU program, the R program, into your clinical workflow. If you can get the subject matter experts in your hospital to design the requirements in their workflow, you've got it hands down. We absolutely can show that they will then follow the pathway because they outlined it. They designed the pathway, right? So it's providers if they have time, it's certainly nurses, it's respiratory therapists, it's pharmacists, inviting the right people to determine their current practice and not forgetting HIM, which controls the legal medical record in most hospitals. Health information management used to be called medical records. Making sure you have milestones clearly outlined because we have very hard dates, prescribed hard dates by the federal government, and then make sure that you have a reporting strategy up to your alliances, your leadership alliances, so that you can have them support you or intervene should you not be able to attain something because of a barrier, whether it's a real barrier or perceived. The other thing I like to point out is make sure you update your policies, right? Policies need to be updated because other agencies that come and audit us, like DOH, and Department of Health, and Joint Commission, they like to see that your policies align with your practice. And it can be easy. You can have one line or two that say, this is how we deal with all of our policies in electronic format. Not to forget that. Okay. Again, this is an outline of what you hospitals, what your role will be. Okay? You need to define the technology that you want, the certified technology, and then here's your part. Making sure you understand the data that's required, making sure you align it with your clinical initiatives, and then stick them into the workflow and analyze whether your design worked in the workflow, make the tweaks you need with your core team. Your hospital core team does this role. And then the rest of it typically is done behind the scenes. Okay? So the integration of the data, the alerts, and the clinical decision support programs that are embedded, they are truly embedded. They are under the scene. So if sepsis is important to you as a hospital, if stroke is important to you, we can integrate technologies that provide alerts to clinicians and other caregivers to provide the outcomes that we want, to guide them on the care treatment plan, to provide the outcomes, the output reporting that we want and need. And then for our cost facilities for implementation, we really need to look at how are you going to actually implement. Okay, and this has to go back to your timeline. What time do we have to implement? If you're looking to a test this year and you haven't implemented everything, which means you have to start your 90-day reporting July 1, likely you'll need to go with Big Bang. You may not have a choice. And Big Bang approaches in cost facilities are very, very successful, but they can be painful. painful because you need lots of resources to support your clinicians 24/7. And we call those resources red shirts and blue shirts. So some resources designated just to help doctors and some to help the operational work efforts of all the other clinicians to make sure your hospital continues to operate and you provide the care you want. And often in Big Bang approaches, we need extended support models, so 6 weeks to 90 days out. We have to have support. And the reason is, okay, because when you do Big Bang, it's kind of it's like an overwhelming aha to clinicians. And after a week or two, they sometimes slip back into old habits. And we got to make sure that that doesn't happen, okay? So we got to have this really aggressive change management. Like if they're slipping back because we designed it wrong despite our best efforts and we need to make a change, that's okay. It's all right. We don't want to do that a lot, but we can do that. But it's more a time when these folks kind of go into workarounds, we call it. And workarounds do not generally meet the federal requirements of data entry in the coded and structured fashion, as opposed to what we call phased-in go-lives or rolling go-lives, very effective as well at cause, where you bring up, certain programs together, like you bring up, e-prescribing and physician documentation together, or e-prescribing and other types of things together. And the reason this one works a little bit, it's a little less stressful for a hospital, although it takes more time, is that the support services that you have to have available are more focused, right? They don't have to be all over your hospital. They're focused on the area of the hospital and the project you're implementing. You still have to have the blue shirts for your docs and the red shirts for all your other clinical systems to make sure your operations are efficiently run. But it is a little bit less painful, and even though you have to have support for let's say 6 weeks, it's not as massive, and in general, you do not see the people slipping back quite as much. A little gentler, but Big Bang works, and we've done both very successfully. Done both. You just have to think about how you're going to do that. And then we obviously want to monitor. We want to give feedback. Feedback to our clinicians is extraordinarily important, right? They love to do a good job because they do a good job. They love to know it. We use red, green, yellow. Green means everything's great. And remember, in our stage 1, the thresholds aren't 100%. Now, what's interesting about hospitals is they want to hit 100%, right? Why am I not at 100%? It's all right, right? We only need greater than 30%. Could we be happy with that? But anyway, however you want to report back to your clinicians, giving them feedback on the great work they're doing, and then targeting the areas that you need to focus on. Okay? And this isn't making massive changes. That's why you want some sort of threshold or dashboard that looks over time, because time gives you a great view of every weekend or every other weekend when this clinician works, our numbers fall. Right? And so it gives you an opportunity to provide additional resources to that clinician to help understand what the barriers are for them. And then process management or project management. This is a key item that we've seen emerge, again, over the last several years, and particularly in the healthcare space, as more and more of these projects are having to be implemented. And project management typically is not necessarily done well with the current people that are hired in the hospital unless you have somebody you've hired to project manage. And I just say that because in most hospitals, particularly our cause, all of these people have tremendous relationships, right? And so if somebody doesn't want to quite meet their deadline or whatever, it's sometimes hard to have those dialogues when you have all these relationships with these people. It can be a leverage point as well, but sometimes a problem. So project managing methodologies really are black and white, and they give us project plans, they give us timelines. They help us identify cost centers. They help us manage cost centers. Are we putting the costs into the appropriate bucket so we can report accurately on our cost accounting or cost reporting? They can really identify where, like if someone has to go out because they're going to have a baby maternity leave for 3 months, that might be the only person from that department on the core team. Right, so they can begin to project and predict those people costs of how you're going to manage that, both in a dollar sense and in a subject matter sense, if we lose that particular person. And then again, soft costs, all the meetings, all the work efforts besides just the specific implementation. They can rapidly identify and predict resource requirements and resource requirements when they're needed. You don't need somebody all the time, but you may need a pharmacist help, let's say, in the month of May, right? And they can begin to outline that early on in the project. They help define an escalation pathway for when people want changes. And I will tell you that people will come out and they will want changes. It's fantastic. We love everybody's great ideas. But it's not likely that we can implement all those great ideas. So we need to have some sort of way that everybody understands of how we're going to adopt the change necessary and how we're going to manage these great ideas from all these creative people who have always been involved in the operational components of our hospital. And so we use things like parking lots or let's put that on the to-do list or the action item list or phase 2 or however you want to define it, because it's a very slippery slope when you start making lots of changes. And again, everybody involved in your hospital is an expert, and they have great ideas. And what you'll have to determine is how you're going to incorporate those great ideas and how you're going to get back to people so you don't discourage that creativity and that innovative, environment that we're trying to create in our hospitals. And then they can track for us. They can create these dashboards and track how we're doing. Now, the last phase of this particular cause is sort of going on, okay, now what? So we've designed our strategy. We know what we got to do. We're marching towards it. Now what? So a couple of things in the now what area is to start your audit books, okay? Starting your audit books, preparing your programs for audit, do a couple of things. One, they protect you, right, when the audits come. And we talked about the audits that are coming. ONC, the Office of National Court, and the Senate is very interested in ensuring that hospitals that attest have, in fact, met meaningful use. That's fair, okay? But the audit books do more for you. They begin to define for you a gap analysis preparing you for stage 2. Right? You will know in your audit book how you met every core and menu objective or which ones you chose to defer. They will outline you to a large degree the work effort required for stage 2. It's fantastic. So you can take your stage 1 work effort, you can put together your audit preparation books, and from that you can glean your current state as it relates to the next journey, which is stage 2, or whatever your next journey is. Organizing that data, right? This is where your project manager can, again, be very, very helpful. And then maintaining that data. Remember, you have to maintain the details for 6 or 7 years, right? You have to maintain and store how you met meaningful use, stage 1. We do not recommend storing PHI in the audit books. PHI, right, protected health information. This is your patient health information, right? That needs to be stored somewhere else, but store it is because that's the data where you got the numerator-denominator value to attest for meaningful use. So very powerful, your audit books. And here's some audit links that the federal government recently released in February about how to prepare for audits. Now, this preparation is more aligned with the CMS audit agency that is coming around and sort of saying, how did you prove? Prove to me that you met meaningful use for the full 90 days consecutively. Now, I did not particularly find these helpful, but it's a start, and the government at least was giving us something, because when we were audited, they gave us a big fat nothing. But that's all right. They're getting better. And then the next thing, so we're going to attest. Now, we're auditing. We got our audit books. We're ready to attest, right? So we're in our 90-day monitoring, and we're working with our finance division, make sure all the registration's ready for attesting. We got our reports in sync. We validated the reports are bringing the right people. We're not implementing. We're not changing in the 90 days, right? We're showing how we've met our established metrics. These are metrics established by the federal government, not us. Not us. And we're saying, all right, we're ready. So during these 90 days, right, because we're in 2013, you can begin to analyze, assess the current state for stage 2. Because you have your audit books, you have your attestation books. You will know whether you included your ER, and whether or not you're going to want to leverage that strategy for stage 2, right? You'll know how you implemented CPOE, and this is a gap area. Some people played a game that they just did a couple of things in CPOE, which is physician order entry, right? Computer physician order entry is what CPOE stands for. Some people just did like 1 or 2 med orders to meet the game, right, to play the game. That's probably going to get you in stage 2. So that will be a large work effort. You could start planning now once you're in your 90-day reporting, right, once you've got your audit books ready. And then really looking at how are you going to engage your patients? What is your community tolerance level? What are your unique features of your community? And then, as you know, the electronic medical or medicine administration record, the EMR. And don't be fooled, stage 2, you must use barcode medication verification. So if you have not used that, you'll need to use that in the future. You'll need to implement that. So in your 90-day reporting period, not only can you prepare for stage 2, you can make sure you're ready for your 90 days, your stage 1, year 2, which is a full 12 months, unless you're reporting this year, in which then your stage 1, year 2 is the 90 days on the calendar, on the recognized quarters, right? So all the rules again, remember the rules. But again, it's a great time to prepare for stage 2 planning. And along that planning journey, it's a great time to sit back and say, okay, what have we learned? What have we learned about preparing and planning and the barriers? What have we learned about understanding the language, understanding the rules, understanding the timeline, right? Did we play the game well? What could we do better? What could we do different? What did we do? Did we do well with our leadership team? Do they need anything else? Do they want something different in our next year? How did we do on strategic planning? Did we align well, or did we have a hiccup because we forgot to stick in that we're moving to a new building right in the middle of our attestation period? That would be a problem, right? How did we align our partners in care, our doctors, our long-term care, our home care, our assisted living, our community pharmacies? How did we align them in this journey? And did that go well? And get feedback from them, what we as a hospital could have done better or different. Metrics, did we meet our metrics? They're going to go up. Did the metrics we set do enough for us? Did they position us strong enough for stage 2 and stage 3, by the way? And then look at our implementation workforce. How did our strategy impact them? Did we burn them out? Are they playing the game with us? Are they interested in continuing? Do we need to give them some fun things like mobile technology, tablets, or other things to make sure that they continue to work with us? And how did our project management or our process management work? And all of that together really becomes an impact statement of how Meaningful Use Stage 1 worked in your particular program today. Okay? And you can then leverage that impact statement for going after, if you're a gap in dollars, you can go after grants. If you have a gap in workforce identified that you thought you could meet in stage 1, but now you're questioning whether you can do that as strong in stage 2, you can really begin to look at your lessons learned and take those strategies, taking the good, leaving the bad, re-engineering the bad to something different, and trying it again. And I'm going to tell you that every time you do this, you get better. So even though we've done, 20-plus meaningful use programs with 20-plus different unique causes, we still learn because each agency has their own unique talents, their own unique gifts, and their own unique expertise that they share, and then we have the pleasure of sharing with the next hospital. So hopefully, with this talk is giving you confidence in engaging today in your hospital's involvement in the Meaningful Use platform as outlined by the federal government, but not just for that reason, not just for the ARRA incentive dollars, but more for your community, positioning your organization and your community of patients very strongly in the next 2 to 5 years of healthcare as the government continues to push towards transformation. And it will position you very, very strongly as you engage with other facilities in your region, whether you choose to participate in an ACO, whether you choose to participate in the statewide HIE. But it gives you leverage, gives you options that you may not have if you choose not to play in this fantastic journey. So hopefully this has been helpful. and I appreciate your time, and thank you very much.